the way I want to do this is to cover topics, to give you a topic. Say we'll talk about postpartum hemorrhage. And I want you guys to reach back and think about all you know about postpartum hemorrhage. And I want everybody to give something about postpartum hemorrhage, what you do, okay? And I think that will trigger everybody, because a lot of times when I'm doing a case study and the same people, or just, people say something, they're too afraid to say something. But let's talk about postpartum hemorrhage, and then you can write down in your notes, okay, this is what everybody said about postpartum hemorrhage. So you'll have it, okay? Because remember what I was talking about before, some of you said you watched Don and Andy, and I was talking about how that one sister was having a baby and during labor, and then she started having to say, I'm not feeling good. And I'm like, okay, she's getting pretty clamsy. I want you to be able to put those things together, okay? So, if we said postpartum hemorrhage, first of all, who's at risk for this? Well, no, I don't want to cut you off, but, kind of raise your hand and say something, so. Okay. Precipitous labor. And precipitous labor is what? Just so we can know what we're talking about. What's precipitous labor? Yes.
Less than 3 hours.
Okay. Less than 3 hours. Okay. And so why is that a concern? Uterine atony. Okay, so everybody knows that. Okay, so what else is another risk for postpartum hemorrhage? Okay. And what is macrosomia? Okay, a large baby. Is a 7-pound baby a large baby?
9
So
pounds.
9 pounds, okay? Okay. And when we talk about a 9-pound baby, what kind of women do we think are going to have this kind of baby? Diabetics, okay? So if diabetics are, if they're a risk factor that they may have macrosomia, then they're also a risk for PPH, right? I just want you to try to tie it together, okay? What are other risks?
Multiple gestation.
Okay, multiples. You guys do know some stuff, huh? Okay, and why are multiples? Why is that a risk?
Stretching.
Stretching of what? Okay, so over distension. Okay, that's what we call that, because of uterine over distension. Okay, and so the same thing. So let me ask you, if you got somebody that's in multiples, so or macrosomia multiples, so we know the uterus is larger, the uterus over distended. She delivers the baby. So what is the concern after she delivers that baby? What is the concern with that uterus? It's atony, right, okay. And so what are we going to do? What are we going to anticipate to do as nurses? Because she had multiples, or she had macrosomic infant, and so she's delivered. So we're thinking, okay, she's going to have uterine atony because of overdistension. So what do we know we're going to do? We're going to make sure we give her that Pitocin, right? Okay, and then we give Pitocin, postpartum Pitocin, always after the placenta's delivered, but this woman, particularly with uterine atony, with a precipitous labor, with a macrosomic baby, even though we know she's going to get Pitocin, what are some other things that we're going to kind of anticipate that could, because of postpartum hemorrhage, that we're going to do? I'm sorry? Okay, but let's not go there yet. We're going to give the PIT, okay? And what else are we going to do? Okay, we're going to be massaging the fundus, okay? And if we massage the fundus, and the fundus becomes contracted, but then it gets flaccid again. It gets. What are we going to do? And and she's still bleeding. What's the next thing we're going to do? What? Assess for lacerations. Well, her uterus we're massaging the fundus and it won't firm up. So if it's not going to firm up, we're not gonna worry about lacerations right then, even though lacerations could be a problem. So what are we gonna do? Okay, we can look for placental fragments, but, okay, that's a good one, but just really remember, if you're massaging and it's not, you want it firm, it's not firming up. The Pitocin isn't working. I'm sorry. No, not yet. We're not gonna get her up. Is she breathing? Yeah, we could give breast. That would be helpful. What we can give her methadone. Yeah. Very good. We can give her methadone. We want to check her blood pressure before she gets methadone. Yeah. Okay. Thank you. We don't want her getting up, walking, and pooling blood. Okay. But know what you're giving your patient. Know how that goes with the postpartum hemorrhage. Okay. And what you guys said was good. That if you're massaging her fundus and let's say it firms up, okay, 5 minutes later she starts bleeding. You look again, and you normally would check in 15 minutes, but you want to check in 5 just because she was bleeding a lot. You look again, there's a lot of blood, and you massage her, she's firm. So then what are we going to think? Lacerations, possible lacerations, or if we're concerned about if there's some placental fragments. And if those are the concerns, if the uterus is firm, she's still bleeding, lacerations, placental fragments, who do we get to check that? Do we do that ourselves? No, then that's when you call your provider, okay? The comment that you made about breastfeeding, that's very important because, and that's a good thing to do, but if you've given PIP and someone is hemorrhaging, then you go to your next medication, okay? What is it when someone, and so let's say if someone tells you that she doesn't want the Pitocin and the IV after the placenta's out after delivery, what is something else that you can give her, you can do? The breastfeeding, because what happens with the breastfeeding? Right, the oxytocin is released, the natural oxytocin is released, and the uterus contracts, because that's what oxytocin does, right? Okay, what is the hormone that, what are the 2 hormones that are responsible for breastfeeding? The prolactin, okay, right, the prolactin is responsible for the milk production, and the oxytocin is responsible for what? The letdown, okay. Okay. So I just wanted to make sure you understand like the procedure of what you do for postpartum hemorrhage. Okay, so how you're going to take care of that mom. If you're giving her Methergin, that you're making sure that you are checking her blood pressure, etc. Okay, checking her blood pressure prior. Okay, so let's look at labor. Well, signs and symptoms of labor. Well, let's see, because we started with postpartum hemorrhage. That's kind of like where we started postpartum, right? Okay, so I'm trying to take you through how we did it. Let's see. Let's start here. Let's take somebody that is coming into triage. Some signs and symptoms of labor. What are some of those? How do you know someone's in labor? Okay, contractions are longer, stronger, and closer together. And you have some cervical change. Okay. What's the difference between, okay, let's say if someone is, what's full-term labor? I'm sorry, full-term gestation? 38 weeks. Okay, anything before that is preterm labor. What's our concern? What is our definition of preterm labor? What is preterm? If someone comes to triage, how can we assess if they're in preterm labor? Mm-hmm.
Before 38 weeks.
Yeah, but someone comes in and says, I'm 28 weeks, okay, and I'm having contractions. How do we assess if they're in preterm labor? Yes. Okay, if they're having contractions, regular contractions with cervical change, okay, because sometimes you can have contractions that don't have cervical change. And what are those contractions called? Braxton Hicks, okay? So preterm labor is when they have contractions with cervical change. Cervical change, okay. Somebody comes in triage and she's 28 weeks and she's having contractions. She's having contractions every 10 minutes. And she's 2 centimeters. She's 20% effaced, and the baby's high. Okay. What are we gonna do for this patient? Her bag of water's intact. What are we gonna do for her? And why are we gonna do those things? Come on, somebody comes in triage. She's 28 weeks. Huh? Okay. We're going to give mag sulfate. And it's a tocolytic. What does that mean? What does that mean? Okay. It's a smooth muscle relaxant and will stop the contractions. Because she's on mag, what are concerns with her being on mag? Respiratory depression, we look for that. So if she has respirations that are decreasing, we're concerned. And what else? I'm sorry? Reflexes, decreased patellar reflexes. Okay. So we're gonna send her over to labor and delivery. We're gonna put her on mag sulfate. We're gonna monitor. What kind of medication are we gonna have at the bedside? Calcium gluconate. Okay. So what else are we gonna give this patient? What else do you think? Right, betamethasone. We're gonna give her steroids. Okay. And why are we gonna give her steroids? Lung development. Okay, because what is the concern about a preterm infant in their lungs? Very good. Okay, respiratory distress because of lack of surfactant. Okay, so we're going to give the baby steroids. Let's say if she's over on labor and delivery for 24 hours. And she doesn't do anything as far as progress anymore. And what does this mean? What does this stand for? And where is this baby? Is this baby low or high or what? What zero station? Ischial spines. Ischial spines. If somebody was +2, where's the presenting part? Two below the ischial spines. Okay. So this patient goes over to labor and delivery, so she's there, and let's say a bag of water breaks. Okay, bag of water breaks, so they send her back over to labor and delivery. She doesn't change. She's still 220 and -5, so they'll give her some antibiotics. Okay, and things settle down. She's over there for a couple days, and they'll send her back over to antepartum. And she's going to be in the hospital for the whole time until she has the baby. Okay, so someone that comes in, this lady happened to be there, but somebody that comes in, she's preterm, she's ruptured, and she's not having any contractions. Okay, this lady's already 220 and -5, but we stopped her contractions with the mag sulfate, so she's not having contractions. She goes to labor and delivery. She gets antibiotics. She's sent back over to antepartum, and she's going to be there for the whole duration of her pregnancy. What are some of the things that we assess this woman for while she's in the hospital? What are some of our concerns that we have for this woman that's, let's say, that's 29 weeks now, she's ruptured, she's not in labor, and she's going to be in the hospital until she's delivered or until she gets an infection. So what are we doing for this woman?
Bed rest.
Okay, bed rest. Well, she can go back. Can she go to the bathroom? Yeah, okay. Okay, what else are we doing for her? How do we do that? Okay, you guys get that, what she's saying, because you all should know that. I mean, that only makes sense, right? She's ruptured. The bag of water is gone. You know, well, the bag of water, it continually the body continually makes the fluid, but it goes out. Okay, sometimes it can reseal, but she is ruptured. She has lost that protection. So she is at risk for infection. Does that make sense? Okay, and so we need to assess that. And the way we're going to assess that, we're going to, she talked about the smell of the fluid, okay? If any of you guys ever smell Choreo, yeah, see if once you smell it, you'll never forget it. It's a certain odor to it. But, and then abdominal tenderness, okay? Abdominal tenderness, the color of the fluid, temperature, you can, look at your labs and all those kind of things, but you can go in the room and do assessment with your hands, with your nose, smelling and stuff like that. Does that make sense? Okay. Someone that ruptures and that's preterm, like I said, they'll give them antibiotics and they'll keep them pregnant as long as they don't get an infection. Once they get an infection, they deliver them. Let's say this woman, what's our normal, and one of the things that they're going to be doing while she's on antepartum, and I say antepartum, but I know you guys, it's like labor 2 or something. That's what it's called now, but it's old antepartum, so I'm old school, so I'll say antepartum, okay, but we're talking the same thing. They monitor her vital signs like every 4 hours, and then they'll monitor the baby. What's normal fetal heart tones? 110 to 160. Let's say if they put the heart tone, the fetal monitor on the bottom, and the heart tones are 90. What am I going to think? That it might be maternal, so you check, okay? You check, and maybe if you have to get the ultrasound to look at it, not necessarily you, but someone that's a provider to the ultrasound. But if the heart tones are like 90, that could be maternal, so you want to make sure that's not maternal. What if the heart tones are 180? What's my thought?
Maternal fever.
Maternal fever. You check mom for maternal fever. Okay, you guys got that? Okay. Okay, so let's talk about labor. How do we know, and we want to see someone in labor after how many weeks? What's our full term that we're trying to get everybody to? 38 weeks, okay. Someone comes into triage, she's having contractions, she's 39 and 2. She has contractions that are coming, they put her on the monitor, she has contractions that are coming every 3 minutes, okay? She's found to be this. What does that mean? And -2, okay. Heart tones are 140s. Positive VAC cells, no D cells, okay? Contraction, what I say, every 3 minutes. So they send her over to labor and delivery, and she gets to be going in labor, and now she's like 7 centimeters dilated, and she's screaming. What are some of the things? When she goes over, she wanted an epidural, but they were really busy, so the anesthesiologist couldn't come right away. So what are some of the things that you can do, non-pharmacological, that can help her in labor? Don't stand and look at her. Come on, guys. Come on. Positioning. Okay. Huh? Pressure points on the back. What else can you do? What is this? Effleurage on the belly. Let's say if she's saying, "Oh my God, my back hurts. Why did you do this to me?" What's going on? She got a lot of back pain. Get on all fours, because what's probably going on? OP. Okay, and OP is that you have the occipital baby's bone in the back of his head up against the mom's spine. So, on all fours, leaning against something, the counter pressure on her back in that area, those kind of things can help an OP baby, okay? The effleurage, the birthing balls, those kind of things, okay? Those things, work to a point, and then mom, says she wants an epidural, okay? So, what are the things that the RN must do before the patient can get the epidural? What is your responsibility? I'm sorry? A liter of fluid, okay. So she gets the IV fluid, and why are we concerned about her getting the liter of IV fluid? Because what can happen and what is that going to hopefully prevent? Hypotension, okay. Hypotension of the mom, and then the decreasing the fetal, which will cause a decrease in the fetal heart rate, okay. So, how many of you guys helped people with epidurals? So you see how they lean up against something and that kind of thing, clean off the area and that. Okay. When someone has an epidural, what are some of the other things that you would do during the part of the labor to help facilitate her comfort? What do you do? What's a nursing process that you do with a woman that has an epidural?
Straight cath.
Hmm?
Straight cath.
Straight cath, or offer her the bedpan or whatever, because she cannot feel that. She cannot feel that she has to void, and the bladder, doesn't need to fill up. So you're straight cathing them every couple of hours. Okay. Is that what most of you guys over at Hurley, they do straight caths, or they just put a catheter in? They did straight caths like every hour or two. Okay. Okay. Let's say this woman, she had an epidural, and so we know that with an epidural, kind of knows from here down. So, and when she came in, 500 minus 2, what stage and phase of labor is she in? I don't want you to tell me. I want you to tell me.
Stage 1.
Stage 1, what phase? So name it, active. It's not called phase 2. Okay, so everyone agree that she is in stage 1, phase 2, an active labor. Okay? When she was home from 0 to 4, what phase was she in? What'd you say? Latent. Okay, so when she was home, she was in latent phase, but now she came in, she's in active phase. Okay. So we give her an epidural. She's 6 centimeters. We give her an epidural. We straight catheter. And so we get to the point now where she is, the midwife comes in, because we're going to have a midwife, right? Midwife comes in. She's 9. She's 100. And she's 0 station. Let's give her a +1. Okay? And she's just like, oh my God, I gotta push! She wants to push. Okay? So, what are you gonna do? Can she push now? She can't push to when? 10. Okay, but what phase is she in? Transition. Okay, and she's transitioned from 8 to 10, right? Okay. So what are something that you can do to get her to do while, so she won't push? Deep breathing, panting is something that they get them to do, to not push, because the concern about pushing, when the cervix is not all the way dilated, so it's not all the way open. Okay, so if they push against a 9 centimeter cervix, the baby's head is pushing up against that, and you can tear it. Okay. So, and then another thing that can happen, it can swell up. If it was even like only an 8 or 7, and she really has an urge to push, she can swell it up. So you want to maybe change her position, get her to pan and breathe and that kind of thing. Okay, so she gets to 10 centimeters, and you're allowing her to push. What is that stage of labor called? Where are we now? Stage 2. Okay, so she's 10 centimeters and she's pushing. And then the provider comes in and says, you know what, I forgot to tell you guys, but I really think this is a big baby, okay? Her last baby was 9 pounds, and this one looks like it's larger, so this might be a 10-pound baby. I don't know. Vaginally, she did a 9 pound. Maybe she can do this 10 pound. Maybe it's only going to be 9.5. So with them saying that, what are you anticipating? Shoulder dystocia. So if you're anticipating a shoulder dystocia as the RN, what is something that you know that you're probably going to end up, the first thing that you're going to probably do when this baby's being delivered? What is it? Mick Roberts. Mick Roberts is pulling those legs back, okay? So that's what you're going to, you're going to be ready to do with Roberts. If they ask when you do suprapubic pressure, if the provider asks for suprapubic pressure, but you know the Mick Roberts, okay? And because you're going to be doing, you're anticipating with Roberts, you're anticipating this large baby, what are you also anticipating? Correct, postpartum hemorrhage. Okay, those are things that are just natural coming. Just like when I heard about the preeclampsia of that lady on Downton Abbey or whatever, I knew preeclampsia, you got to know postpartum hemorrhage. This is what I need to do. This is what's going to happen because it happens very quickly. Okay, so the main thing, we talk about prevention, health prevention. This is the anticipation, and you're going to have to be able to, as you go through school and then as you finish, you're going to have to be able to work with that, pick that up, and have that thinking in your mind. That's that critical thinking. Okay, so she delivers, and she delivers the baby, and baby's out. So where are we? What stage are we in now? Okay, baby's out, and then placenta comes out, and when we look at the placenta, how many vessels, how many cords do we look for? Okay, yeah, so we look for 3, yeah. Wait a minute, 3 arteries, 1 vein? Okay.
3 vessels, 2
3 vessel cord, 2 arteries, 1 vein. Okay, Ava, just remember that. Okay, and then we look and make sure that all the pieces are there. Okay, and there's nothing left inside. And so after the placenta's out, the provider looks to see if there's any lacerations, that kind of thing, cleans the person up, and massages the fundus and make sure it's firm and stuff. Okay, so this baby comes out, and you're there to catch the baby. Okay, so what do? You get this baby in your hands. What do? You dry the baby off. Okay, well, why is that important? Okay, very good. So we're gonna dry the baby off, and mom told you that she wanted baby skin to skin. Okay, so you dry the baby off, put baby on the chest. So and you put the little blanket on top. Okay, so nurse asked you, well, did you get the baby's Apgars? I don't know, baby's on mom. Did you get the Apgars on the mom? Yeah. What do you do when you're getting Apgars? What are Apgars?
Appearance, pulse, rhythms, activity, respiration.
Did you say color?
Appearance.
Okay, yeah. Okay, so know your Apgars, and it's out of 2 points. You can get 2 points for everything. 2 points for each 5 things, but nobody gets 10 out of 10. So it's usually, and people are usually off for color. Okay, usually off for color. So you do Apgars when? 1 minute and 5 minutes. Okay, you do Apgars. Okay. So you dry baby off, Apgars are good. You don't do the baby's blood pressure, you do the heart rate. You look at, and let's say you hear some grunting. Baby's respiration should be about what? Okay, if baby's respirations are 66, what's my concern? When they're over 60, what is that called? Louder. Tachypnea. Okay, tachypnea. And sometimes tachypnea is just transit, but we watch that baby. Okay. When mom's bag of water was broken and it was green fluid in there, yeah, the fluid was green. What is that? What made that fluid green? Meconium. What is our concern about a baby that's born and the mom had meconium? Okay, aspiration. So what are we going to do with that baby? Right, suction before the shoulders, and they do all that as the nurse would take care of that baby. What are we going to monitor that baby for? Respiratory distress, possible pneumonia, etc. Okay, because of getting that meconium down in there. Okay, so we have the baby, we drive the baby, baby's on mom. We did our APGAR scores. Temperature is fine. Heart rate's 140s, that's fine. And let's say if mom didn't want the baby but went under the warmer instead, and mom's going to breastfeed, when do we want to encourage mom to take baby and breastfeed? First period of reactivity, okay? Because the first period the baby's more awake and alert, and after that period, baby will sleep for a while. During the breastfeeding, mom's breastfeeding and she complains, this is her third baby, and she's complaining, oh my God, I got all these cramps, what is going on, this hurts. What's happening? After pains. And why do after pains happen? The contractions, and the contractions happen because of the oxytocin that's being released as the baby suckles. Okay, everybody knows that, right? Okay, good. Okay, so mom does her recovery, she does fine. We already talked about the postpartum and that's what you would do. So mom goes to postpartum, baby goes to the nursery. Let's say if when this mom came into triage and she tells you, like, she takes you to the side and says, I had a history of, they told me that I had herpes, but I never had an outbreak. So, but I was told to tell you that when I came in labor. What's your concern with that information? Okay, so you would look to see if she has an active lesion. And let's say you don't see anything, so okay, that's fine. She can go ahead and have a vaginal delivery. Let's say if she has something that you think looks like it could be herpes, she has a lesion there, what would you do? What's your concern? A C-section, okay? Because the concern would be what? Why are we doing a C-section? Right. So the baby, when the baby comes through the birth canal, baby comes through that area, baby can pick up the virus and baby can pick up the herpes, okay? If a mom during prenatal care, mom has a history of herpes, typically what they do is do suppression. So at 36 weeks, they'll take a Acyclovir or something to suppress that happening, so she can have a vaginal delivery. Okay. So make sure you review all of your baby care. I know we did this a long time ago. Let's say if this mom is going to, we're breastfeeding the baby, and she tells you that her nipples hurt, and she's not sure if the baby is getting enough food in. I don't know if I'm going to continue breastfeeding. What are some of the things we can tell her? Number one, if her nipples hurt when she's breastfeeding, what's the first thing that we want to do? Yeah, make sure that the baby's position, okay, the baby is positioned well on her breast, okay? If her nipples hurt. Not about, let me see, well, you want to look at it, but, you're not worried about putting lanolin on it or anything like that. You want to see how the baby is positioned. What is the cause of this, okay? And then you can look at putting some colostrum on her nipples and let it dry, and lanolin and those kind of things. But the main thing you want to do is the positioning, okay? Check out the positioning. Say you have a mom that is not going to breastfeed, okay? And what are some of the things that you tell her about her milk coming in and what to do, because she's not going to breastfeed for comfort? What do you tell her? Okay. Wear tight-fitting bra. When you take a shower, you're not having the warm water go on your breast, but on your back. And you don't because what's going to happen, if you think about this way, the breast milk's going to come out, it's not going to come out. Your breasts are going to fill up, and then you don't stimulate them at all to relieve some of the milk, even though that's what they may want to do, but you just leave it alone and let it reabsorb, okay? Because if they squeeze some of the milk out because their breasts are real firm and it's uncomfortable, then the body will make more, because the body will think, oh, okay, you're nursing, okay. The mom that's breastfeeding, she's concerned that, I don't know if this baby is getting enough milk. How do you tell, what do you tell her to do to know that the baby's getting enough feeding? Count the diapers, and how many diapers should you take? 8 to 10. 8 to 10 diapers will let us know that this breastfeeding mom is getting enough food. Well, not the mom, the baby. Okay. Mom asked you, okay, so when should I give the baby cow milk? 1 year. That's what the pediatrician society says. 1 year, okay? And breastfeeding, is encouraged for all lactating women except HIV. Doesn't matter HIV because they can pass that virus through their breast milk. So we discourage, and it's not like we can't allow because it's their baby and stuff. But you discourage HIV women from breastfeeding. Okay, a breastfeeding mom that talking to you about contraception. What kind of contraception can she not have? Any kind of contraception that has estrogen. Okay, so she can get the progesterone, she can get the condoms and foam or whatever, but just nothing with the estrogen. And speaking about birth control with estrogen, what about if you have someone that's over 35 and a cigarette smoker? Should they be on birth control pills with estrogen? No. Okay, because they have an increased risk for the thrombo and the strokes and stuff. Okay. Let's say we had babies, when we talk about NICU, some babies, preterm babies that go to NICU. You have a baby that, how can we identify, and we're concerned about a baby with increased cranial pressure. How does that baby, what are some of the signs and symptoms that we will see in a baby with increased intracranial pressure? Okay, what else? How the right, and an increased circumference, head circumference. Okay, the same. How do we identify a baby with? I think we talked about. I feel like I went over so much of this stuff, but is this helping? Oh, okay. NEC, necroenterocolitis. NEC. How do we determine? Thank you, necrotizing enterocolitis. What's some of the signs and symptoms? Blood in the stool, distended abdomen, abdominal distension. Okay. The baby that the breastfeeding mom has, the next day, well, in the nursery, we're going to give them how many injections? 2. If they sign and say that's okay. And what kind of injections are we going to give them? Hepatitis and vitamin K. And where are we going to give them? The vastus lateralis. Okay. Okay. This mom, when she delivered, because we thought that she was going to have a large baby, the provider cut it a episiotomy. Tell me the 3 types of episiotomies. Huh?
Midline lateral, medial lateral.
Say them again?
Midline lateral, medial lateral.
Okay. 3 types of episiotomies. Usually, the midline is what you see here in the States. The midline EP is the one that goes. Oh wow, this is really crazy. The midline here, or that's what we normally see in the United States, but in this way, providers providers that are English trained, they'll do the laterals. Okay. What's the most, okay, and one of the things that, you know, we tell the postpartum mom, you know, to make sure she washes her hands and those kind of things, because nosocomial infections are caused a lot by people that are what, not washing their hands. What's the most common postpartum infection? Most common infection on postpartum endometritis. Okay, that's the infection of the uterine muscles. So you want to make sure people are washing their hands and stuff. Let's say if the mom complains about, wow, my breast really hurts, and there's this area here that's red. What's your concern? What may be going on? Mastitis. What is the number one organism that causes mastitis? Staph aureus. Okay. Okay. So let's talk about, any questions about any of this? Okay. Well, you know what? Let's talk about, we talked a little bit about labor. Let's go over some of the concerns of labor. Let's say if, let's talk about somebody being pregnant, starting, okay. What's one of the concerns, why do we want preconception counseling? What's the purpose of having someone come in before they're pregnant? Okay, to find out about genetic abnormalities, any history of genetic abnormalities. What else? Prenatal education, what they can be doing. What else? Okay, put them on folic acid. How much folic acid are they supposed to be on? 400 mics daily. Okay, folic acid. And let's say if they have a history of high blood pressure, let's say if they're diabetic, okay? We want to make sure their hemoglobin A1C is good. We want to find out if they have seizures or something. We want to find out what kind of medications they're on and that kind of thing. Make sense? Okay. So we get these people in for preconceptual counseling. So they come back, they're pregnant. How do we figure out their due date? Nagel's rule, what is that? Know your Nagel's rule. +7 - 3. I think that's right. I just use a wheel, but yeah. Know your Nagel's rule, okay? And so someone comes in, we get their due date, and let's say we find out this person is, the person's unsure about the first day of their last menstrual period, okay? So how do we find out about their gestation? An ultrasound for dating. When you're early, an ultrasound for dating, okay? Let's say, what was I going to say? Do an ultrasound for dating. Let's say this person comes in and she says this is her third pregnancy. She has one child that she had at 40 weeks, one child that she had at 28 weeks, and both children are living. What are her G's and P's? What? Everybody sees that? Make sense? Know your G's and P's, know how to calculate that. Okay? I won't give you twins, but you know, twins are one pregnancy, and then you'll tell twins because you got more on the living side, right? Okay. And if for some reason you have less on the living side, then somebody died. Okay? Okay. So know your G's and P's. Let's say we find out that this person had a 9-pound baby. So what's our concern? Was she a gestational diabetic? Okay. And we asked her, was she just, because we did her history and she has no history of diabetes that she showed us. And she said, no, no one said anything about her being a gestational diabetic. What will we do for her that day in the office? We have her do an early 1 hour glucose test. Say it comes back negative. So she's not gestational diabetic, and that's not a problem, but do we repeat it again? We repeat it at the regular time. Okay. Let's say if she is, let's say we find out that she's, let's say she had a history of, let's say she's 8 weeks. Okay, she's 8 weeks. No, let's say 10 weeks. She's 10 weeks, and she had a history of a baby with Down syndrome. Okay? So, her and her partner, they wanna know, is it possible that this baby has Down syndrome? What could we do for her? A CVS. We can send her to genetics. We can send her to genetic counseling for them to talk, and then we can get someone to do a CVS. Does that make sense? Everybody follows that? Okay. And so what is the CVS? How does the CVS help us? What do we find out from the CVS? What? Correct. The material we get from the CVS is the same as the baby's chromosome. So that will let us know if baby has Down syndrome. If there's anything else chromosomally that we can find out. Okay? Now we do a CVS when? We can do it in 10 weeks. We can do this first trimester. Okay? Let's say if when this person comes in and she is 16 weeks, this is somebody else. She's 16 weeks. What is a test that you can think about that we're going to be doing probably 16 to 20 weeks? What did you call it? Quad screen. Oh, okay. Quad screen. Okay. Yeah, the quad screen, the AFP, MSAFP, AFP quad screen. Same thing. Okay. So we do that 16 to 20 weeks, 15 to 20 weeks. That test comes back abnormal. What are we going to do? What are we going to do? We're going to check the dates. We're going to make sure that we have a correct gestational age. We should say, I really wasn't sure about my last day of my period. So we want to check those dates. Does that make sense? We're going to check those dates, okay? And then we check the dates. If they could come back and they recalculate it and it's normal, so it's fine. But let's say it's abnormal. It's still abnormal. So what do we ask her to do, or tell her her option is? What can she do? She can do the amnio, okay? And so the amnio, you find out she's Rh negative. What's your concern? When we're going to do an amnio, she's Rh negative. If the baby's, we're going to do an amnio. So what are we going to do? She's yeah. Oh, but you said the baby, if the baby's positive. How do we know if the baby's positive or negative? We don't. So we're just going to give her Rogaine because she's Rh negative. Anybody that's Rh negative, she falls down the stairs, she's in a car accident, question about possible abruption, whatever. We're going to give her Rogaine because we don't know what the baby is.
If they know the father's negative,
Then they usually know. Yeah, then it's good. Yeah. If that's the father.
I know.
Yeah, that's what, yeah. But not saying that it's not, but yeah, but the mom, she's positive. Okay. So she'll get Rogaine. We'll know that she'll get Rogaine. So if so we know that at 26 weeks that she's gonna get her testing for diabetes, and every time she comes into the office, she gets her blood pressure taken. She's getting a urine checked. What is a urine check for? What do we check her urine for? Protein, and we look for ketones for diabetes, but protein. What's the concern about the protein in her urine? Preeclampsia. Okay. Tell me the difference between chronic hypertension, gestational hypertension, and preeclampsia. Chronic hypertension. I came in, I got hypertension. I have hypertension and I'm having a baby. I had it before. Yes. Okay. What's gestational? Gestational hypertension, yes. Okay, everybody got that. Gestational, you develop it after 20 weeks. Just like gestational diabetes, you develop diabetes after 26 weeks. Okay, because what happens is the placenta hormones causes insulin resistance. Okay, that's just kind of like a normal thing. You know, a lot of people's bodies, they handle it, and it's fine, but they don't get gestational diabetes. But, so what is preeclampsia? With proteinuria. You gotta have the proteinuria, okay? That's the thing, you gotta have that proteinuria for it to be preeclampsia. And then our concern is for, and when they come in and say they're preeclamptic, what is the drug of choice we put them on? Mag sulfate. We put them on mag sulfate to prevent what? To prevent the seizures, which is called eclampsia, okay? And once they, you know, when they're preeclamptic, they come in, they're on mag sulfate. We talked about all the things you got to do for a patient on mag sulfate, the preterm labor or preeclampsia, same stuff you do for mag sulfate. The concern would be, okay. They're usually on mag sulfate. Anybody have a patient on mag sulfate after they delivered? Okay, because usually they kept them on for what, 12 or 24 hours afterwards? Okay. She had eclampsia, and then did you see her seize? Were you there?
She was in the PICU actually, because she was 16, and it was after PICU.
Okay. And then one of the things that they do is, okay, so they'll wean them off and, what was it? Preeclampsia, okay. Now I'm losing my train of thought where I was going with this. See the live stream making me nervous. No, it's not. Preeclampsia, the seizures.
Mag sulfate after delivery.
Mag sulfate after delivery, and I can't think of it. Okay, whatever. Don't come back to me. Okay. So what were some of the other? The same thing. If we had someone thinking about things that can happen during labor to people that have medical problems, pre-pregnancy, what about if we had someone Marfan syndrome? What is our concern with that woman in labor? Pushing. Why? Aneurysm, because of the connective tissue disease. So remember the Marfan syndrome. Okay, that's a concern that we have. Okay, let's take it back to this woman that is in during her prenatal care. And let's say she's 32 weeks now. Anybody that has some type of health history with chronic hypertension, chronic diabetes, maybe even asthma if there's a problem, any type of chronic problems that they have and they're concerned about the baby, what they can do how can we, let's say at 32 weeks, we want to start monitoring this baby to see how baby's doing. Okay, maybe mom said there was decreased fetal movement at one time. What is the way, what can we teach mom to do to assess fetal well-being on her own? Fetal kit counts, and we talked about that, 10 movements in 2 hours or less. Okay, let's say mom comes back and she says baby's not moving like it usually does, which is like 32 weeks. What do we do? What? Non-stress test. We send them for NSTs. Remember that? The NSTs, the non-stress test, okay? And when we do, and let's say we have her going twice a week. When we do an NST, what are we looking for? Accelerations. How many? Tell me about what are accelerations? Number one.
15 beats above baseline for 15 seconds.
Okay, and we want how many in a 20-minute period? 2. Okay. What does that tell us? I'm sorry?
Good explanation.
Right, good oxygenation, baby's doing good, okay? So we want to send her for NST, so we want to get the accelerations, okay? And let's say if we don't get accelerations, and mom is still, and so we call the provider, okay, we're not getting, baby's not reactive, we tried to get mom to drink some juice or whatever, baby's not reactive. So what is the next thing we can do? Biophysical profile, okay? And we do a biophysical profile. And when we do a biophysical profile, what are we looking at? Respirations and the fluid. We look at active movements and muscle tone. Okay, so the way it goes, the NST looking for accels. The NST is not good. We do a biophysical profile. They have a half hour to get these to, we measure the fluid. They got a half an hour to do 30 seconds of breathing, to do 3 kicks, to do a certain amount of movements, okay, to make sure that this is fine. If the biophysical profile is not good, or we're not sure about that, we're not, if that's really good, what's the next thing that we do? Okay, CST, a contraction stress test. When we do a contraction stress test, what are we looking for? We want 3 contractions. We want the mom, we do something so the mom can have 3 contractions in a 10-minute period, okay? If, let's say someone's coming in for NSTs and they're already 39 weeks, they may be having contractions, okay? They might be Braxton Hicks, but they're having contractions. They may be having contractions on their own 3 to 10 minutes. So what we want to do is look at how the baby is reacting to contractions, okay? So if we see what's going on here? Late. Everybody see that? Those are late decelerations because it happens after the contraction comes up after it's over. Okay, those are late decelerations. And this would be considered, is this a positive or negative stress test? Not stress. Yeah, contraction stress test. Is it positive or negative? It's positive, okay? I mean, you would think it's not good, it's negative, but it is positive. It's a positive contraction stress test, okay? And this person is not going home, okay, with a positive contraction stress test. Okay, what do we call a fetal heart rate that looks like this? What are those? Those are earlies. Everybody see that? I mean, it doesn't look like, I mean, it's like, but I just wanted to emphasize. What causes this? Head compression. They're okay. All you do is, you chart what's happening, okay, but that's okay. Earlies are okay. What are these? Variables. What causes variables? Core compressions, okay? So you can think about somebody that has oligo. Oligo is what? Low fluid. Okay, somebody that has oligo, they can have a lot of variables because there's not a lot of fluid in there to float that core. Does that make sense? Okay. So that's core compressions. What is something that we can do in labor and delivery for someone that is having a lot of variables besides changing the position? They're ruptured. We're changing the position. What can we do? Amnio infusion, right? Makes sense to put that fluid back up in there. Okay. Okay. So let's say during prenatal care, this woman, Jeff Beck, during prenatal care, patient comes in, she talks to you about, nausea and vomiting. She's a little nauseated. What are some of the things that we can tell her that she can do besides crackers? And eating maybe small frequent meals. What are some of the other things that we can tell her, some of the alternative therapies that we can tell her she can do to decrease the nausea and vomiting? The C-bands and ginger, okay? Okay, is this is helping? Is this still helping? Okay, so, okay, let's see, so, okay.
What all do you want us to teach for intimate partners?
Oh, okay, good, ask me questions. Good question. What do we want to teach a woman about intimate partner violence? It's not her fault. It usually, you know, it can reoccur. You know, you can't, different from what you learn in PEDS for, I forget the name of the form that you have the responsibility to notify, but you don't with intimate partner violence. But you help her put a plan together. You tell her it's not her fault. You try to give her support, that kind of thing. Patient that has, when we're talking about labor, preterm labor, fetal fibronectin test, okay? Patient with a positive fetal fiber, do you know, somebody tell me something about fetal fibronectin?
Possibility of having baby within 2 weeks if it's not.
Okay, possibility of having baby within 2 weeks if it's positive. So you have a patient that's she has a fetal, she had a positive fetal fibronectin test. It came back as positive. She's not having any contractions right now. Provider says, okay, go ahead and send her home. Put her, you know, tell her to have, you know, not to go to work. Drink a lot of, you know, 64 ounces of water a day. And when do you want to tell her to come back to the hospital or to monitor? What is she really going to be monitored when she's at home?
Okay.
Contractions. She starts having contractions again because she can go into labor in, within 2 weeks. So you have her make sure she comes back. Okay, she's having contractions. This mom that's in one of your patients, when you do her initial blood work, you find out that she has a positive, she's positive for sickle cell trait. So, what kind of teaching, what, you know, you find that out, you tell her about that when she comes back in, and what is the next step that you want to do, that you want to talk to this patient about? Mm-hmm. Right, have that tested, okay, and you send them to a genetic counselor, okay? Patient tells you that she has a lot of cats at home. What's your concern about that? Toxoplasmosis, so it's okay for her to have the cats, but you don't want her cleaning the kitty litter, right? Okay. When we talk in, okay. What's when we were talking about postpartum hemorrhage, and you guys take a look at talking about gestational diabetes, multi-gestational patients, well, somebody with multiple gestations, anything that's going to stretch that uterus. What about, don't forget, polyhydramnios, okay? Polyhydramnios is what? Increased fluid, okay? What's the purpose of the amniotic fluid? Temperature regulation. Okay. Did everybody hear her? Okay. And so if someone has poly, remember the positions of the baby. Baby that, if someone has poly and their water broke, what's a real big concern? Somebody with polyhydramnios and the water breaks. Cord prolapse. Okay. Patient cord prolapse. What kind of position are we going to put her in when we see that? Yeah, all fours and knees check, but yeah, like So, and we're putting fingers in, and what you want to do is prevent the presenting part from being on the cord. And people, you keep your fingers in there to prevent that until baby's out. That's a stat C-section. Can you visualize that? Okay. Anybody else have any particular questions? Okay, so.
Question for them, theory, if there's an asthmatic, postpartum hemorrhage, and they have high blood pressure, what do you do?
An asthmatic postpartum hemorrhage. You gave them Metrogen.
If they have high blood pressure.
If they had high blood pressure, side attack,
With their asthmatic. You
hemobate.
can't give it to them.
Hemobate. Huh?
With their asthmatic.
But they're asthmatic. That may be a person that they take back. Let's say they have a condition you can't give them drugs. Somebody like that, they may take back into the OR. Anybody have a postpartum hemorrhage at all? Because when students get that, are part of that, they get really excited to actually see that. Because sometimes you may have to take someone back to the OR, and they put them asleep, and they go in the uterus and clear anything out. Because what could be happening is there's fragments in there, or we talked about accretas before, okay? And particularly that happens if someone's had a history of a C-section or a history of some type of uterine surgery. And with the accreta, the placenta is like embedded into the muscle. And it depends on the depth of it. An accreta, percreta, increta, percreta, there's another one. I've never seen an accreta, but what typically happens is that if they can't stop the bleeding, then they're going to do a hysterectomy. Okay? And that's rare that happens, but it does happen.
That's what I think of what they could do if they couldn't hear the bleeding.
Yeah, they couldn't stop the blood, yeah. But that usually happens more so after C-section. It's what they call a C-HIS, a cesarean hysterectomy. But if they have bleeding, any kind of postpartum bleeding, and they can't stop it, if they cannot use the medication, if somebody's an asthmatic, let's say they're not a real bad asthmatic, and if they're bleeding, they may give them the medication. You know what I'm saying? Okay. Okay, let's make sure I cover. What's my hormones that are related, that we talked about related to pregnancy? What is the purpose? What did I hear? Estrogen. Okay, and what does estrogen do? What's the purpose of the estrogen?
Proliferation of blood vessels.
Okay, and what does it do to muscles? It's like, yeah, progesterone is a smooth muscle relaxing. Okay. Know your postpartum blues. Okay, the difference between your baby blues, which is kind of like the normal thing, your depression versus the psychosis. Because in the psychosis, you're talking about delusions, hallucinations, insomnia. Your psychosis is, think about Andrea Yates. That's that hallucination. Somebody telling her, "My children are evil. I have to kill them." Okay. Let's talk about some GYN stuff. I'm not going to go over it here, but I want you guys to go over your menstrual cycle. What is the purpose of your FSH? What does that stand for? And what does that do? It tells you what it does. What does it do? It stimulates the follicles, so the follicles can what? Release an egg, okay? When the ovaries release an egg, what is it? There's sometimes a woman feels a pain during that time. What is that called? Right. Middle Schmitz. It's a German word. What did you say? It's weird.
It's German.
Yeah.
The spleen market, I think, is the surgical consistency. Yeah.
Well, the spleen market is the mucus.
Yeah.
Yeah. But the middle Schmitz is the pain that a woman may feel when she releases an egg. Yes.
SH. Isn't that the period of the vitamin as well as deficiency?
The spin bucket.
No, FSH.
Oh, the FSH. Yes, yes, yes. So when you have, where is a embryo usually fertilized? In the fallopian tube. Okay. Okay. Okay, so usually in here. What happens when a person has histories of PID? What can happen to the fallopian tubes? Scarring tissue. And that is one reason why, and what can happen if you have scarred tubes? What's your concern? Ectopic pregnancy, okay? Okay. So you fertilize here, you come down here, if the baby is, if the egg is fertilized, it embeds here in the uterus, and then the person skips a period and they find out they're pregnant. Did we talk about implantation bleeding? Was that something in the book? Okay, maybe that was something else. Okay. So we won't get into that. Okay. Let's see. When a person, so this person missed their period and they came in and they said, I think I'm pregnant. What is some of the reasons when she misses her period? What is a hormone that will appear? HCG, okay? That's human chorionic gonadotropin, okay? That's the hormone that's picked up when she's pregnant, okay? But let's say she hasn't taken a pregnancy test yet. What are some of the presumptive signs of pregnancy that she may be having? Why does she think she might be pregnant? Okay. Anything else? She might be nausea. She might have breast tenderness, but those are things that could be something else. Okay. So, and we talked about this the other day. The presumptive, those are the things that the woman thinks that may be happening to her. The probable and the positive. And we know the positive. You feel heart rate, you see the baby on the ultrasound, that kind of thing. Anytime you have a question, just let me know. I'm not going to go over them, but I want you to make sure you go over I see here on page 351, box 11.1, look at your categories of abortion, okay? When we talk about, and I don't want to go over all of the different types of birth control, but go over your different types of birth control, the teaching that you would do. We've already talked about with what someone is breastfeeding, what kind of birth control they can have. Someone, let's say, what are some of the things you want to assess for someone that wants to use birth control pills with estrogen? Let's say combination pills, estrogen and progesterone. What is one of the main things that you want to make sure that they don't have a history of? DVTs, right, thrombophlebitis. Okay, you want to make sure, or you want to make sure they're not over 35 and smoking cigarettes. Okay, thrombophlebitis, someone that, so if we think about our GYN stuff, even looking at adolescents, we want to make sure that what's the number one killer of adolescent females? Is accidents. Okay, accidents. What's the number one killer of women? Heart disease. Why do we do pap smears? Looking for cervical cancer. And what puts people at risk for cervical cancer? HPV and cigarette smoking. let's see. If a woman, when we talk about mature women, and okay, with adolescents and adolescent girls, we want to make sure that they're increasing the amount, they're having an appropriate amount of calcium intake because of, hopefully to prevent osteoporosis when they become adult women and older women, perimenopausal women. And when I speak of perimenopausal, menopausal women are women that have what? Stop their periods, and they have not, they stop their periods for how long? 1 year. Go back 1 year and they haven't had a cycle, okay? And the menopausal woman is at risk for what kind of symptoms may they have in menopause? Once they go through menopause. Hot flashes, vaginal dryness, and what can we tell them about that for the vaginal dryness? Water-based lubricants. Let's say if someone comes and she hasn't had a period for 2 years when she starts bleeding intermittently. What's our concern for her? Endometrial cancer, postmenopausal bleeding, endometrial cancer. If she has some type of abdominal bloating, the concern would be ovarian cancer. Okay. Women that are postmenopausal, perimenopausal, elderly women, we want to be concerned about them exercising. Walking would be good for their bones. Okay. Because jogging would be good too, but if they do have a walking, yes.
I'm just so glad that you want us to put a little bit of education or the science of menopause. Do you have a hormone replacement therapy?
A study guide, I got study when I do what now? The question about menopause and menopause patient teaching the new signs and symptoms. Yeah. Yeah. No, it's not about me liking, but what you want to do. Hormone 10 years ago, they would put everybody on HRT because they thought that it would decrease heart attacks. Okay, and they studied, they stopped the study early because what they found was an increase of breast cancer, and it didn't do anything with heart. Okay, and the reason why they thought that was because men had a higher number of heart attacks compared to women, but women's number of heart attacks increased after menopause. So they figured they'd give an estrogen vaccine to increase the number of heart attacks in women because that was the change, that was the difference. The women lost their estrogen. But putting women in this study, putting women on the HRT, the hormone replacement therapy, what they saw was vast increase in breast and uterine cancer and no decrease in heart disease. So they took them off. So the signs and symptoms you want to teach would be, what to do to decrease the vaginal dryness and those kind of things. And you always want to, you can always offer them, and today they say offer them HRT for the shortest amount of time possible because of that study. Okay, but before it was like a carte blanche, So you want to teach them to eat well, decrease caffeine, sugars, those kind of things. A diet like that, a healthy diet to prevent, some of the symptoms of menopause. And then ask your mother what she did. Basically. Okay, if she remembers. IVF. Who would use IVF? She can't get pregnant. What could be her problem? Okay, PID, ectopic pregnancy. So what's the problem that she has because she had PID and the ectopic pregnancy? Scarred fallopian tubes or blocked fallopian tubes. Okay, so we do IVF. Because in IVF, what we do, we take the embryo and put it into the uterus. And we don't even need the fallopian tubes because we're not there. Okay. I'm getting tired, guys. So are we good? You guys good? Huh? Okay, let me tell you. I think you're good. I think you're good. I think I gave you guys a lot of stuff. And I think if you go over your study guide, the stuff that we talked about in class on the last day, the really, and I don't need to go over this with you, this, the ethics laws and standards of care, know these definitions. You know, if something says, know these definitions and when to use them, I think you'll be good. You should be good. There's no doubt in my mind, okay? And if you don't, shame on you. Okay. Have any questions, shoot me an email, but I think you guys should be good. So we'll see you Tuesday at 10:30. If I can think of any burning thing, I will send you an email. Just give me 2 seconds. Let me.
I'd like to, did you take the one point that's I-16?
I have not done that. I will do that before we get together on Tuesday. I apologize, but I will do that.
Thank you for letting us stream it.